Hi everyone, welcome to the final week of our class. This week we'll be talking about epidemics and pandemics. First, let's clear up a couple of these terms. A pandemic is defined as an outbreak of an infectious disease that occurs over multiple countries or continents and affects a significant portion of the population. Some examples of pandemics would be the COVID-19 pandemic and Mpox today in the 2020s. The Ebola outbreaks in the 2000s into the 2010s, the swine flu pandemic in 2009, and the Spanish flu in the 1920s. An epidemic, on the contrary, is a widespread occurrence of an infectious disease in a community at a particular time. So some examples of epidemics would be HIV and AIDS in the United States in the 1980s, 1990s, as well as polio in the US in the 1950s into the 1960s. It's important to understand, though, that pandemics and epidemics are not super clear-cut categories. These can be kind of blurry, different concepts. Epidemics can very easily become pandemics as they get larger and larger in scale. The difference between these is really about how fast the disease is spreading and how widespread it becomes. This week we're going to do kind of a deep dive into HIV and AIDS, a great example of an epidemic, as well as in some cases a pandemic around the world, as there are very high rates of HIV and AIDS in different regions around the world. That could look like a bunch of small epidemics, or we can consider this a pandemic of kind of a smaller scale. HIV and AIDS are widely misunderstood by a lot of people in our general society. So I want to clear up some concepts and some definitions for us to get started. First, HIV stands for the human immunodeficiency virus. It is a chronic illness if a person has an HIV infection, which, as we've learned about chronic illnesses, this means that it is treatable but not curable. AIDS, which is acquired immune deficiency syndrome, is something that can happen when an individual has an HIV infection. Not every single person who has HIV will develop AIDS, but over time, this is a possibility for some individuals. However, we are very lucky that today we have treatments that are way better than ever before in the history of HIV and AIDS. Antiretroviral medications, they can actually stop viral replication, which is that virus reproducing itself within the human body. And that medication, we have examples called PrEP and PEP, which I'll talk about in a little bit more detail. They can actually prevent the eventual progression to AIDS status for an individual who is HIV positive. It's really important for us to understand that HIV is the human immunodeficiency virus, so any human being can get HIV. It is not something that is specific to any particular group of people. Any person can have an HIV infection. And unfortunately, a lot of people don't know when they have HIV. They're not aware of their positive status. And this can happen for a lot of different reasons, but the way that symptoms for an initial infection occur are not all that different than a flu or a cold for a lot of people. Usually about 2 to 6 weeks after exposure to HIV and after that infection begins, a person might have flu-like symptoms for about 1 or 2 weeks. And so a lot of people might not think very much of this. They might think they just have a cold or a flu. And after that, 7 to 14 or so days of those symptoms, the symptoms will go away and the person might feel that they're just back to normal. And a person can actually stay asymptomatic for several years, not knowing that they have HIV, being completely unaware that they have those viruses replicating within their body. And during that period of time, the virus can actually do some damage to that person's immune system and to their body if left untreated. And so it's really important to know your status, to know if you are HIV positive or negative, and the only way to know this is to get tested regularly. And so, especially if you're someone who may be coming in contact with others who have an HIV infection, if you may be potentially getting that infection yourself, and it's very difficult to know if you are or are not potentially in that situation, just given all of the factors that could lead to HIV infection, which we'll discuss later in this lecture. But getting those STI screenings, getting tested for HIV is the only way to know your status. And so if you do get tested regularly, you can avoid that situation where if you are perhaps someone who is HIV positive and asymptomatic, that you are not going those several years with that virus damaging your immune system without your knowledge. It is important, though, to understand that there is a window period after infection where, if you are aware that you were exposed to HIV, or whether you're aware or not, if you get tested too soon after the infection begins, you can get a false negative on that test. And so, regular tests are really the best way to make sure that you are aware of your status. Um, because it's just very difficult to know if you are not getting regularly tested because of that window period, because of those kind of confusing flu like symptoms, and the possibility of being asymptomatic entirely. So, definitely a really good idea to get tested regularly if you're not already doing so. To dive into a little bit about how HIV infection works, HIV can be transmitted through bodily fluids like semen, vaginal and anal fluids, blood, and breast milk. It is not transmitted through sweat, urine, or saliva. So it's totally okay to kiss someone, touch someone, shake hands with someone who has HIV. If you're bit by a mosquito or another insect, even if that bug has bit another person who is HIV positive, it won't be transmitted to you in that way. It's completely safe to swim with people who are HIV positive, to be in the same room, to share food and drinks, to share a bathroom. All of that is completely safe. Um, the possibility of transmission or getting infected with HIV from another person could happen through sexual contact, sometimes through pregnancy, if a pregnant person may pass on the virus to the baby in that case. Needles as well, sharing needles like injection equipment or needles used for drug use that can transmit HIV, blood transfusions, non sterile tools, like if you go to a tattoo parlor and they don't have those clean, new, fresh tools for every individual. Those are all situations where there is a risk of HIV transmission. Luckily, if you are exposed to HIV, there is something called emergency anti-HIV medication, also known as post-exposure prophylaxis or PEP medication. If this is taken within 72 hours or 3 days after that possible exposure, it can prevent HIV infection after exposure. There's also a medication called PrEP or pre-exposure prophylaxis, and this is used by people who are at high risk of infection. So if they have a sexual partner or a romantic partner who is HIV positive, the person might take PrEP to be able to reduce the risk of becoming infected with HIV themselves. Now, looking at the way that the United States handled the HIV and AIDS epidemic in the 80s and 90s, this was not just a medical epidemic, this was kind of a moment of mass cultural hysteria and a lot of homophobia and transphobia. So the epidemic first started in the 1980s, and early on, the media was kind of acknowledging that something was happening, something was starting, but there was a lot of stigmatization that was happening in those representations. There was kind of this assumption that HIV and AIDS was linked with what they called the four H's at that time. These were people who were heroin addicts, homosexuals, Haitians, and hemophiliacs. Of course, this is a very discriminatory way of talking about individuals, but that was what we were seeing in the 1980s at the beginning of this epidemic. And so individuals who were using substances that required needles, um, gay men and transgender women, people who were from Haiti, and people who have the disease hemophilia, where they have um, a disorder of the platelets in the blood that prevent clotting. A lot of these individuals will need blood transfusions, which at the time, blood transfusions were not tested for, or donated blood was not tested for HIV because this was a very new crisis. And so individuals in those categories or who were a part of those communities were being affected at higher rates than other people. And so this assumption was that people in those communities were having these high rates of HIV infection um, because of their lifestyles, behaviors, morality, and things like that. And of course, we understand today that Viruses do not care about the lifestyles or the politics or the individual characteristics of the people they infect. Viruses have no morality or value system. They are just kind of biological mechanisms that infect other living beings. So that's where we started at the very beginning of the epidemic. And then we moved into the next stage of moral panic. And this is where the media was kind of spreading this idea that infection with HIV was kind of like a deserved punishment for immorality, that people who had HIV infections were being punished, or that they deserved that infection for something bad that they had done, bad behavior, poor lifestyle choices, deviant identities, and things like that. There was this very discriminatory label placed on the HIV epidemic. Some people were calling it the gay plague at this point in time. Of course, we can see all the reasons why that is extremely problematic, but this is an important part of history at this point, that the way this epidemic was handled told us a lot about our sociocultural values and revealed a lot of issues within society and healthcare. As we moved on to the next stage in this epidemic, we started to get to that crisis management stage. So there was a little bit of knowledge, a little bit of research that had been done. This was starting to be understood a little bit better. And so some knowledge was being spread to specific groups about how to avoid HIV infection. And interestingly, the groups that were getting this education were not always the groups that were being affected by HIV at the highest rates. So, as I mentioned before, those groups, the so-called 4-H's, those were the individuals who we saw higher rates of HIV infection. We saw a lot of people developing AIDS within those communities, and the people who were actually receiving the education on how to avoid infection and how to treat or live with HIV tended not to be the people in those often disenfranchised groups, and on the contrary, tended to be higher income, usually white, usually straight individuals. As we came up on a decade with this pandemic, this epidemic, into the 1990s, the representations started to change a little bit, but they were still largely pretty discriminatory. We had these tropes of the victim, the survivor, and the carrier being HIV positive individuals. Carriers were people who lived with HIV, people who were, HIV positive, but they were going about their lives and not necessarily extremely sick at this point in time as medications were developing. It was because of that development of antiretroviral drugs that carriers were even possible, that people could live with HIV instead of eventually succumbing to HIV through the development of AIDS. We also had some other tropes during the 1990s about the so-called guilty gay man, deserving of punishment, this idea that gay men and also transgender women were immoral individuals, were deserving of this punishment, and often this was linked to Christian ideals and other kinds of religious ideologies during that period in time. We saw a lot of media representations of these kinds of ideas being perpetuated. And on the contrary, this representation of so-called innocent people who contracted HIV. Innocent, I put in air quotes here because, of course, again, we know that viruses do not have a moral compass in who they infect. People who do get HIV are not bad people. They are not immoral people or deserving of that in any way at all. But these ideas, right, the way that HIV was understood and the way that this epidemic was understood and was framed, specifically because of the people who were affected at these higher rates, especially people in the LGBTQ plus community, all of these ideologies came kind of wrapped up in one package together where these innocent people, or the people that were seen as innocent, were usually white individuals, straight individuals, higher income individuals, and people who were seen as less deviant within society at that point in time. There was also a lot of blame placed on sex workers during this period in time. A lot of people believed, and a lot of the media perpetuated this idea that sex workers were responsible for the spread of HIV, which of course is very unfair misrepresentation. As we move into the second decade since the beginning of this epidemic into the 2000s, we start to see some change about the way HIV is depicted in the media, the way that people are talking about the issue and the disease. But a lot of the time, we still see these depictions of HIV as a death sentence. This really fear mongering, negative kind of representation, not really showing people living with the disease, not showing people who are HIV positive as complex human individuals, but more so as those stereotypical kinds of tropes. Um, One thing that we did start to see in the early 2000s, though, was that a lot of people who did have HIV started to kind of feel this drive to take better care of themselves as these evolving media representations were out there, as the research around the disease was developing, as medications were developing. There was a growth in hope within the communities that were being affected at higher rates. And so, as things were starting to improve a little bit here and there, um, media representations started to catch up to that process as well, very slowly. And of course, there is still a long way to go with this, but that evolving media representation was slowly starting to become a little bit more positive. Before I jump into the content on this slide, I'd like you all to think about what you have seen in the media about HIV and AIDS. What messages or what stories have you seen? What have you learned about this disease from movies, from TV shows, from newspapers, podcasts, any media that you're consuming where this is a topic? Chances are it was perhaps not the most positive representations, and that's pretty typical for HIV and AIDS media representation, especially when we go back to the beginning of this epidemic in the 1980s. A lot of those representations were very moralizing, very sex negative, extremely homophobic and transphobic, just very, very problematic. And a lot of the ads that we saw, a lot of the PSAs, a lot of the information that was being put out, especially on TV broadcasts, these were aimed at white individuals, wealthy, straight people, people who at that time were considered by the dominant people in society as um, more worth protecting, right? They were not being devalued and stigmatized and discriminated against at the same rates as or really at all compared to the individuals who were being affected by the epidemic. And so this really fear-mongering approach to discussing HIV and AIDS was not helpful and served to further stigmatize the individuals who did have HIV. A lot of the time, these ads and these PSAs really overlooked risk management or harm reduction or ways to reduce your chances of contracting HIV. They really didn't talk very much about safe sex practices or how to, again, reduce that potential risk through still living your life. A lot of the time, these ads focused on pushing that monogamy is the best way of life for individuals and their relationships. They encouraged people to avoid so-called deviant behavior, which usually included things like sex work, drug use, or any kind of same-gender sexual activities. Um, and while we've come a long way with media representation of HIV and AIDS, it has not been all that long since the very beginning of this epidemic. It's been, 40 some odd years, and we have seen a lot of growth, but still a lot of these same fear-mongering and sex-negative kinds of depictions. We're starting to see a little bit more diversity and a little bit more realism in representations in this area, which is awesome. It's a big, big step forward, but there's still kind of a long way to go in this arena. I've included a few videos here in this lecture that I would encourage you to watch on your own. I'll put these links up on Canvas so you can go find the one on this slide and the video on the next slide. Please do go watch those, and then we'll jump into a little bit of a discussion about these representations of HIV and AIDS. All right, so once you've watched those two videos, I'd like you all to think about what you think those ads are supposed to make the audience feel. what kind of message are they sending? What is the goal of creating ads like that, of creating PSAs like that? Um, these very fear-mongering, kind of scary, kind of negative sorts of depictions of HIV and AIDS. Um, what is the goal of those? Do you think that those types of ads are effective? Are they informative? Are they useful? And if not, why would a different approach possibly be useful or functional instead of this fear mongering approach, instead of this really scary, very problematic, honestly, kind of representation? What are other ways that we can spread information about things like harm reduction and safe sex practices and instead of this moralizing, homophobic, transphobic, classist, and problematic fear mongering type of representation, what other ways could we spread that information and give people the knowledge and the empowerment to be able to avoid HIV infection if that's something that they want to do? How can we do that effectively? It's also important that we acknowledge, the ways that unfavorable representations, like those two videos, how they can harm the LGBTQ plus community, Black and Indigenous and people of color, and people who are potentially sex workers or drug users. Um, of course, we have a lot of ways that that representation can be harmful to this community, but different approaches to this representation and spreading that information can be really useful as well. So handful of questions to think about here. Of course, we can't have an in-person class discussion on these topics, but it's definitely something worth exploring um, with yourself and thinking about a little bit further because this is something that we are surrounded by all the time is media representation. And whether we'd like it to or not, it does teach us kind of how to think about these sorts of topics. Switching gears now to talk about pandemics now, I'll use the COVID-19 pandemic as an example this week. The COVID-19 pandemic, we are probably all very familiar with. We've been living through this for the last handful of years. But as far as a little bit of a timeline with the COVID-19 pandemic, in the end of December 2019, the pandemic began in China. By March of 2020, it was declared a pandemic by the World Health Organization. So only about 3 months there. Of course, this is a very quick progression to pandemic status. That is one of those important key traits of a pandemic is how quickly and how widespread that disease becomes. It wasn't until December of 2020, so about 9 months after that declaration that this was a pandemic, that the first vaccines were made available. They were not made available to everyone all at once. They were made available to select populations early on, and then over time they became available to everyone. And then in the years since, there have been booster vaccines and new vaccines developed as the virus has also changed over time. As we get to kind of our modern period of time in October of 2023, there were almost 7 million COVID deaths so far worldwide that are documented COVID deaths. The number is likely a lot higher. There are a lot of countries that are not collecting regular data about COVID. There are a lot of people who have died of related comorbidities and issues in conjunction with COVID. And so these numbers are pretty difficult to track accurately, but we know at least 7 million people, probably quite a few more people have died from COVID so far since the beginning of the pandemic. One really important thing that we want to look at as medical sociologists is that there is a lot of inequality in a pandemic, and that should really come as no surprise. But even in the United States, there's a lot of inequity in which individuals are infected, who is treated, what kinds of treatments are available, the cost of those treatments, the accessibility of those treatments, and then, of course, the morbidity and mortality of a disease like COVID-19. There's a lot of inequity in who dies and who is injured or ill long term from a virus like this. Some of the inequality that we saw during the COVID-19 pandemic is amongst the high-risk groups. So that would include older adults, disabled individuals, people with chronic conditions and comorbidities that increase their risk of COVID infection or negative outcomes of a COVID infection, as well as low socioeconomic status individuals. The reason why low SES people are included in this high risk group is because a lot of low SES people have jobs that may be low income jobs that cannot be worked remotely. This could be food service jobs, service industry jobs, jobs where people are interacting with the public on a regular basis. Often these can be also very stressful jobs, and we have talked quite a bit this semester about how living in poverty can also compromise a person's health in a variety of ways. And so, with those existing factors, when a pandemic emerges, low SES people are included in that high risk category. Um, those pre-existing health concerns due to poverty, that stress experienced in poverty, environmental pollution in a living environment, experiences of discrimination, which of course that could come with intersections with race, disability, all kinds of other identity factors. All of these factors combine to create a high risk situation for a lot of the members of our community. And then beyond the immediate health risks of the virus itself, during a pandemic, there are a lot of non-health related impacts. A lot of people experienced poverty, job loss, relationship difficulties, mental health struggles, abuse in their family or their home life, and so on and so forth. There were also, of course, if we're looking at disability in particular, a lot of disabled people experiencing abuse because even without the pandemic, the rates of abuse against disabled people are higher, but the pandemic kind of amplified the risk that a lot of people were facing. A lot of disabled people might rely on their caregivers. They may be, um, living at home in a space where they don't have the possibility or the resources or options to be able to leave the home for mobility reasons, for transportation reasons, or because of the pandemic itself. And so a lot of individuals have this potential of risking being institutionalized or losing their agency or dealing with a lot of very difficult decisions and situations because of that reliance on caregivers that may or may not be abusive, that may or may not be affordable, that may or may not be reliable during a time like the pandemic. We do know that there's a 1.5 times higher chance that disabled people will experience abuse at the hands of their caregivers compared to non-disabled individuals. And so during quarantine, a lot of disabled people were at this very high risk situation. We also saw a lot of eugenicist attitudes that were circulating during the beginning of the pandemic and also throughout. These ideas that only disabled people, people with pre-existing conditions, or older adults are going to be affected. So I don't really care. It's not a big deal to me. I'm not worried about this virus. A lot of these attitudes that kind of devalued the lives of those high-risk groups. And we can consider that a eugenicist attitude because it's really devaluing the lives of people who are already disenfranchised or oppressed or discriminated against, particularly disabled individuals. When we see these patterns of thinking or these ideologies that devalue those lives and kind of say, well, it's not a big deal if disabled people die from this virus, that's not me, I don't care. That kind of attitude has a very far reaching harmful effect, especially during a pandemic situation where that attitude, if widespread enough, which it was very widespread during the COVID-19 pandemic, can have some really far reaching negative effects. It's also really important that we understand that isolation, even in 2023 and onwards, still hasn't ended for a lot of disabled people and for immunocompromised people. The COVID-19 pandemic, as well as other concerns, are not completely gone, right? There are still a lot of health concerns in the environment that mean that a lot of people still have to isolate and quarantine themselves to avoid those health risks. And of course, being isolated for a long period of time has some really detrimental effects on a person's social life, their potential employment, and their mental health. During any kind of emergency healthcare situation, such as a pandemic or an epidemic, we might see these practices called medical rationing and triaging. Medical rationing is limiting the availability of some medical care and resources for certain populations. And this takes place because there is unfortunately not an unlimited store of resources of, beds, respirators, medication, and so on at every hospital for every patient. And so with those limited resources, some rationing can become necessary in certain situations where there are so many patients who need treatment, but there are limited resources. And so healthcare professionals have to make a determination about who gets those resources. And that can be done, or that decision can be made through the process of triaging. Triaging is where you assign different degrees of urgency to wounded or ill patients. So this can happen in the event of, say, like a natural disaster after a hurricane or a tornado, but this can also be in the case of a pandemic. We can assign different degrees of urgency, such as immediate urgency, or we can delay treatment a little bit with some patients. Some patients can be turned away. Maybe they're not doing so badly that they really need treatment at all. Maybe they're just very minorly wounded or minorly ill. And some people may be completely fine in a triaging situation and they don't need any kind of treatment whatsoever. So that triaging practice, again, can be a very difficult, very stressful emergency situation. And in the event that not every single person can be treated because of limited resources, some very difficult decisions might need to be made. And so healthcare providers during these kinds of situations, they're trying to decide who gets treatment and who doesn't. And that can be decided a lot of different ways. Sometimes there can be a randomization element to this where every patient is essentially kind of drawn out of a hat. And if they're randomly selected by chance to receive treatment, then they do. Um, there are other practices that some hospitals might use where they try to preserve the longest number or the largest number of years of life. And so they might treat younger patients and kind of um, put older patients on the back burner and kind of ration in favor of the younger patients. This might also include disabled individuals. They may be less likely to receive care because of this idea of disability adjusted life years, where hospitals or healthcare workers are encouraged or are deciding to prioritize non disabled life years. And so, particularly people with visible disabilities might be neglected from that care, might not be able to get treatment in that kind of case. Um, of course, these issues are wrapped up in a lot of very difficult decisions. It's a situation where there really are no right answers, and with limited resources and too many patients to treat, difficult decisions are going to have to be made. But within the disability rights activism community, we have a push for more disabled healthcare workers so we can bring those voices of disabled individuals into the spaces where those decisions and policies are being made. We tend not to see a lot of disabled healthcare workers, not a lot of disabled doctors out there. And of course, that can be because medical school itself can be a very ableist, very inaccessible environment. And so when we have a lot of non-disabled healthcare workers and non-disabled doctors and non-disabled policymakers deciding how triaging should work, how medical rationing should look, um, we can see this devaluation of older adults and disabled individuals. Um, there are a lot of reasons why we could, or a lot of ways that we could improve these practices, but unfortunately, these are probably going to be a reality of healthcare for a very, very long time to come, because in the instance of a medical emergency or a natural disaster, of a pandemic, all of these kinds of things will typically have a situation where medical rationing becomes necessary, triaging becomes necessary, and we really want to be thinking about how do we make equitable decisions in those kinds of cases and make sure that we're not perpetuating classist or racist or ageist or eugenicist kinds of views. Now, when we think about pandemics and epidemics, we have this idea that there is an end to them at some point. And it's very difficult to define when a pandemic actually ends. For the COVID-19 pandemic in particular, we do know that quarantine at the beginning of the pandemic, the practice of social distancing and masking, having good hygiene, and getting vaccines and boosters, all of these practices helped to save a lot of lives. But of course, a lot of lives were still lost. Also, most people are not really practicing these habits anymore. Most people are not still in quarantine or still isolating. a lot of people are not social distancing or masking at this point in time. People may have kind of dropped off their hygiene practices and are not being quite as diligent with perhaps their hand washing. And while boosters are still available for the vaccines, not everyone is necessarily keeping up with those or getting the vaccines in the first place. And so, as those practices kind of start to dwindle, and the society at large is not engaging quite as cohesively in these practices, um, we tend to see these surges in COVID-19 infections that tell us that the pandemic is really not over. Um, Again, it's really difficult to define when a pandemic ends, but COVID-19 has actually started to become what we call endemic. And this is kind of like the flu, where a disease stays around, but it's kind of better understood, it's pretty predictable, it's fairly treatable, and we have good vaccines, good medications to kind of handle COVID-19. And so what a lot of epidemiologists are expecting is that COVID is not going to go away. It's going to become a little bit more like the flu, where it kind of surges up, particularly during the colder months of the year, perhaps every year, probably from here on out. And so, with that in mind, it's important to still be vigilant about this virus as well as the flu, and do what you can to stay healthy and stay safe and keep the other people around you healthy and safe as well, because this is something that we are living with moving forward. Just like HIV and AIDS, there are a lot of different diseases that are just a part of our reality at this point in time. And while it's getting better and better as far as the treatment that we have and the medications that are available for all of these different diseases, it's still very important to be informed and aware about these issues so that you can make the best decisions for your health and the people around you. But thank you all for being here this week. I am sorry to conclude our class. I have loved teaching all of you this semester, and I look forward to another great semester with any of you if you choose to take one of my classes in the future. Thanks.